Hi everyone, welcome to ResearchMD.com. Another great presentation today. We're going to continue our series on endocrinology, right? We've made so many lectures before, make sure you watch it. Let me introduce myself again, Pramil, Cheriyath, a physician practicing in the United States, program director in internal medicine residency, transitional residency, and I teach medical students and residents on a regular basis, associate professor of medicine, two large medical schools. Now, let's talk about our subject, okay? It's called MEN syndrome. What is it, MEN? When you say MEN, multiple endocrine neoplasia, okay? What is the first thing we have to do? We have to look at the definition. Let's read the definition. Group of heterogeneous. The word, remember, is autosomal dominant, okay? And then characterized by tumors of two or greater endocrine glands. So many endocrine glands are affected, my friends. Pancreas, thyroid, parathyroid, pituitary, okay? So that's what makes it so complicated. But it's very challenging, exciting for a physician to diagnose. Because as an internal medicine physician, you have to put all this diagnosis kind of together, right? So you cannot just go each way, but put them together, come with a diagnosis. That's like a detective's work. That's why it's become very fascinating. Okay, so I'm going to start on this side, and then let's start with there's four types. First of all, we need to know. Okay, well, what are the four types? MEN 1, okay, and then MEN 2, MEN 3, and MEN 4. To make the things more complicated, I mean, there's usually before they used to call MEN 2 as 2A, MEN 3 as 2B, and MEN 4 kind of recently added. Okay, just remember the classification. MEN 2, we put it in the bracket. It's also 2A and 2B. Okay, now just look at MEN 1. We'll just start on the MEN 1 first. And the first thing we need to know, what's the prevalence of MEN 1? Okay, what is the MEN 1 prevalence? 1 in 30,000. Okay. So it is, I mean, I wouldn't say it's not uncommon, okay? So MEN 1 in 30,000 prevalence. What is the involvement? There's three major ones we have to know. The first one is like the parathyroid adenoma. In parathyroidinoma, you mainly got primary hyperparathyroidism. You got like nephrolithiasis, nephrocalcinosis. You can have renal failure, bone loss. Okay, remember those are the first one. Again, parathyroid adenoma. Now you have like pituitary adenoma. Anytime there's like a pituitary adenoma or mass, you have to think about hyperprolactinemia. You got galactorrhea, infertility, right? And then you got that is hyperfunction. You got acromegaly, gigantism. You got central hyperthyroidism, Cushing disease, gonadotropin secreting tumors. There is hypofunction, and then you can have the mass effect on the pituitary adenoma also. Okay, just comes, I mean, again, pituitary adenoma, you got hyperprolactinemia, you got hyperfunction, hypofunction, you can have a mass effect also. The other thing is the pancreatic neuroendocrine tumors. We'll start with the gastronoma. You got peptic ulcer, and diarrhea is very common in that. You got insulinoma, which produce hypoglycemia, okay? And then you got glucagonoma, which is which can cause like crash, weight loss, and then VIPoma. Usually the presentation is like watery diarrhea. So it's good to know all of this presentation. And last, you got skin manifestation. You can have like, simple lipoma, angiofibroma, and collagenoma. So remember the three major type. In MEN 1, the prevalence is around 1 in 30,000. You got parathyroid adenoma, and then you got pituitary adenoma, and then you got pancreatic neuroendocrine tumors like gastronoma, insulinoma, glucagonoma, and VIPoma. Okay, now let's look at the what is the chromosome. It's all these mutations, right? When we talk about the mutations, what mutations also we need to know? The mutation is the MEN 1 gene is located on the chromosome 11q13.1. It's a tumor suppressor gene, okay? So the mutation, we need to know that is the MEN 1. Now, if you look at like when you have the MEN 1, when do you suspect these people, right? We don't know, because so many endocrine functions are like kind of interconnected in this, right? So when do you suspect? When do you test for these people, right? So when do you test? If you have more than or equal to 2 MEN 1 tumors, tumors. When you talk about parathyroid or pituitary, okay, that's the number one you have to suspicion become high. And then you got one men-1 tumor, plus first degree relative with the men-1, then you have to be like, consider testing. And then familiar isolated hyperparathyroidism, you need to consider testing. Parathyroid adenoma, and you have somebody like a parathyroid adenoma, especially like less than 40 years, we need to consider testing. Okay, then you have GDP, gastro-duodenal, pancreatic, neuroendocrine tumors, okay? And then you got bronchial or thymic neuroendocrine tumor, that's the other time you have to consider testing. So it's good to know what situation we have to test, right? And then you got, how do you treat it? Pretty much, surgery have like a lot of things to do with most of them. Like parathyroid adenoma, you take it out, right? And then prolactinoma, what do? Everybody know you got dopamine agonists. Then you have like pituitary lesion, again surgery, and then gastronoma, you can do PPI and H2 blocker, and then insulinoma, gluconoma, and VIPoma, then you have to do surgery. So think about surgery, except, right, prolactinoma, you start with the first line is like dopamine agonist, right? And then gastronoma, you can do PPI and the H2 blocker. Okay, remember that. So that is in a nutshell, that is what men want about it. Okay, now let's move on to men 2. And again, we need to know the prevalence. What's the prevalence? Men 1, again, 1 in 25,000, right? It's more common. So men 2 is very more common. So if I remember something, I remember men 2 more than anything else. Okay, now men 2, what are the what are the main 3 things in here? You got parathyroid adenoma. Again, just like men 1, parathyroid adenoma, we talk about, primary hyperparathyroidism, nephrolithiasis, nephrocalcinosis, right, and renal failure, bone loss. Remember, parathyroid adenoma. Then you got something extra right here, medullary thyroid cancer, which produce calcitonin. The symptoms can be diarrhea and flushing. So again, medullary thyroid cancer. And the third one is Pheochromocytoma, which we gave. Make sure you watch our presentation about Pheochromocytoma. Great presentation. We need to know the 5 P's, right? What are the 5 P's? First, we start with the palpitation, P, pain, headache, and the P for perspiration, P for pallor, P for panic, okay? The first 3 is the triad, making the palpitation, pain, and the perspiration. Those triad is a classic symptoms, but remember, 5 P's for Pheochromocytoma. Remember that, okay? Now, skin manifestation will be cutaneous and it's actually cutaneous lichens and myelofibrosis kind of changes going to be there. And let's look at the the chromosome abnormality or gene mutation. This is RET gene. You need to remember that. RET gene, they might ask you for a question for examination purpose. It's a proto-oncogen in the chromosome 10q11.2. All right. So when do you test for these people? When is our suspicion become really high, right? You got any one of those 3 tumors we mentioned, you test it. And plus, anytime you have somebody have medullary thyroid cancer tested, and anytime you got preganglioma, you test it, and you got relative with the known pathogenic mutation also kind of tested. Okay. Now, how do you treat it? Again, when you have medullary thyroid cancer, again, you do a total thyroidectomy, and then you have to dissect the cervical, lymph node. And then, when you come to the pheochromocytoma, you should do, you can do adrenalectomy, all right? And this should be done before the surgery for medullary thyroid cancer. Always remember that, it's a good point. And then when you do this, make sure alpha blocker, beta blocker are needed to be done before you do the adrenalectomy, right? Now, let's look at the MEN3 2B or MEN3. What is the prevalence? 0.2 in 100,000. Okay, so you don't have to know that much about it, but it's good to know what's going on in there. Again, so let's go back and see what is the MEN3. First one, you can have like ganglioneuromatosis in mainly the GI tract, like 90% of the time, and then it can be tongue, lips, and the musculoskeletal also. And then you got medullary thyroid cancer. We already talked about produce calcitonin, diarrhea, flushing, and then we talk about the pheochromocytoma. The 5 things. What are the 5 things? Again, 5 palpitations, pain, pallor, and perspiration, and then panic. The first three are the triad, which is like palpitation, pain, and perspirations. You can also morphine or habitus and low doses in this patient. Okay, remember that. Now, where is the chromosome abnormality is a gene mutation, right? So here, red gene again, just like this here, photo-oncogen, and which is on the chromosome 10q11q. And when do you any of this tumors you suspect, you do the testing, and you have first related degree with medullary thyroid cancer. Make sure you check for MEN2, and then treatment again, the same treatment over here, medullary thyroid. Medullary thyroid cancer. You do thyroidectomy plus cervical node resection and pheochromocytoma, just like before. Adrenalectomy should do before surgery for medullary thyroid cancer. Remember that, okay? And then you have to do the alpha blockade and beta blockade. Now, let's look at the last one, which is the MEN4. Again, it's very less, very rare, but you still need to know that. First one is parathyroid adenoma. We have primary hyperparathyroidism, nephrocalcinosis, nephrolithiasis, renal failure, bone loss, and then you got pituitary adenoma, just like over here. Which is the one you have to do the prolactinoma. You have to know hyperfunction and hypofunction. You got the mass effect, and then you got also the you got the pancreatic neuroendocrine tumors, which include gastronoma, insulinoma, glucagonoma, and VIPoma, okay? And we have the symptoms. So remember, it's the same as pretty much as the MEN1 and MEN4. It's pretty much similar. And only difference is it got, remember the word right here, renal involvement, adrenal involvement, ovarian failure. If you have that involvement, you can say it's pretty much a MEN4. Now, what is this CDNK1B gene involved? It's a tumor suppressant gene and chromosome 12p13.1. And we don't have much data about when do we testing. I guess any of these tumors you should consider testing, that probably. And then parathyroidinoma, the treatment, we know like surgery. When you have prolactinoma, you do dopamine agonist. Pituitary lesion, you do surgery. Your gastronoma, you do PPI-NH2 blocker. And you got VIPoma, glucagonoma, and the other insulinoma, make sure you do the surgery. So let's look back and see what is the common. How do we remember this? So remember, if you look at MEN1, right, you got this parathyroidinoma, hyperprolactinoma, pancreatic neuroendocrine. It's the same thing in MEN4. Okay, remember that. Don't forget it. You got parathyroidinoma, so you can kind of pretty much that. Only difference is MEN1, MEN4 in the renal involvement, adrenal involvement, ovarian failure in MEN4. Okay. Now, when we look at it, parathyroidinoma is also in MEN2. Okay, remember. And then pheochromocytoma is also in same thing, right? Pheochromocytoma is MEN2 and MEN3. Okay, and then you got medullary thyroid cancer in MEN2 and MEN3. Remember that. Okay, so let's look at the similarities from both. So we can remember it's better. Okay, when you look at again MEN1, let's do MEN1 and MEN4. Pretty much similar, but make sure you got renal involvement, and then you have the ovarian failure and adrenal involvement also common. Right? So when you talk about pheochromocytoma, it's only like when you talk about 2 and 3. Okay? When you talk about medullary thyroid cancer, you got 2 and 3. Right? Now, parathyroidinoma, you have MEN1, MEN2, and MEN4. Okay? And only thing one special is ganglioneuromatosis in the GI tract is for like MEN3. That's probably the best way to kind of remember that. So just make sure, before you take any test, it's very, very important, not only taking tests in the patient care situation also, okay? So just going to summarize like one more time. Remember, like I'm going to go a little bit faster here. MEN1, you got 3 things. So what is it? You got parathyroidinoma. Okay, the second one, you got pituitary adenoma, and then you got pancreatic neuroendocrine tumors. Okay, and then we talk about the MEN1 gene, chromosome tumor suppressant gene. Make sure, like, when what situation we need to test it. The mainly thing is the surgery, but again, if it is a prolactinoma, then you have to do dopamine agonist, and you got gastronoma. Make sure you give PPI and plus H2 blockers. Okay, that is MEN1. When you talk about MEN2, you got parathyroid adenoma, and then you got medullary thyroid cancer, Pheochromocytoma, and you got RET gene, if you remember that. And then role of surgery, remember that. And then MEN3, you have ganglioneuromatosis. That's a little bit special about that. You got medullary thyroid cancer, Pheochromocytoma, again, RET gene involved, but the chromosome now is 10q11.2. The same thing, pretty much over here, okay? And then MEN4, you got parathyroid adenoma, you got pituitary adenoma, pancreatic, neuroendocrine tumors, but the involvement of renal involvement, adrenal involvement, and ovarian failure make this kind of distinct from type 1 or like MEN1. And then you got parathyroid adenoma. The treatment is pretty much same. You got parathyroid adenoma, you do surgery. You got prolactinoma, you do dopamine agonists. So again, one more time, just make sure that look at the similarities. Let's look back and this good thing when you put everything on a whiteboard, right? So MEN1 and MEN1 and MEN4 are pretty much similar, right? The presentation. Only difference is renal involvement, adrenal involvement, ovarian failure. Pheochromocytoma, you got MEN2 and MEN3. Medullary thyroid cancer, you got MEN2 and MEN3. Okay? And then you got parathyroid adenoma, MEN1, MEN2, MEN4. Okay? And ganglioma, neuromatosis kind of status on is in MEN3. Okay? Thank you so much for watching. Please make sure you continue to repeat watching again, because this is like you have to like memorize a lot of these things in this. Very, very important topic. So please study hard. Thank you for watching. We'll be back with another presentation soon.